Hello, everyone, and welcome to the Radiology Cardiothoracic Imaging podcast. My name is Sonia Barra, and I'm the editor-in-chief of the journal Radiology Cardiothoracic Imaging. The host of our podcast is Praveen Ranganath from Dallas, Texas.
Hey, Dr. Ibarra. Hello, everyone.
Hi, Praveen. In this series of podcasts, we will break down recent articles and trending topics from the journal through conversations with the authors, the editors, and experts in the field. For all of you out there interested in cardiothoracic imaging, subscribe and listen to the podcast to keep up to date with recent developments in cardiothoracic imaging.
Hello, listeners, and welcome back to the Radiology Cardiothoracic Imaging Journal podcast. I am your host, Praveen Ranganath. On today's episode, we will discuss a recently published original science paper in the journal. The paper is titled Deep Learning Quantified Calcium Scores for Automatic Cardiovascular Mortality Prediction at Lung Cancer Screening Low-Dose CT. This paper comes to us from our colleagues in the Netherlands. The lead author is Dr. Bob de Vos, and the senior author is Dr. Ivana Izgum. On this episode, I speak with the lead author, Dr. Bob de Vos, on this important work, as well as his journey into the field. But first, a little background. The patient population eligible for lung cancer screening is often afflicted by more than just lung cancer. Due to overlapping risk factors, these patients often also suffer from cardiovascular disease, substantially more so than the general population. Patients enrolled in lung cancer screening programs undergo serial, low-dose, non-ECG-gated CT scans of the chest, which are treasure troves of information for stuff beyond just characterizing nodules. Thus, there is a great incentive to gather opportunistic information about cardiovascular disease risk from these low-dose chest CTs. We know from many large trials and cohort studies that cardiovascular calcifications are a powerful disease biomarker. The featured paper on this episode aims to apply this knowledge about calcifications to lung cancer screening CTs in an attempt to predict cardiovascular mortality. So the featured paper is a retrospective sub-study of the National Lung Cancer Screening Trial. As a refresher, the National Lung Cancer Screening Trial was a very large 50,000 plus patient randomized control trial that compared the performance of lung cancer screening with radiographs versus that with CTs. Eligible patients were aged from 55 to 74 years of age and had at least 30 pack-year smoking history. Long story short, CT was superior and resulted in earlier stage diagnosis of lung cancer and fewer overall deaths. Okay, let's get back to the featured study. Of the 26,000 plus participants in the low-dose CT arm of the trial, around 5,500 were included in this paper's analysis. That's 4,400 in the training dataset and 1,100 in the test dataset. The investigators developed an automatic deep learning-based tool to quantify cardiovascular calcium. A few unique things here about the methodology. The investigators first converted the non-gated CT data into cardiac CT-esque data. Then, the investigators quantified aortic, valvular, and coronary calcium in those images. Next, the images were separated into evenly spaced slabs, and the calcium scores were calculated for each of those slabs. Lastly, the slab-based calcium scores were used to predict 5-year cardiovascular disease-related mortality. The performance of this deep learning calcium technique was also compared to a prediction technique using more traditional self-reported patient characteristics. All right, so what were the results? Well, the short answer is that the image-based prediction tool performed well at predicting cardiovascular death, better than just using traditional risk factors. Now, for the nitty-gritty of those numbers, I will refer our listeners to the paper. Okay, so I'm sure a lot of you out there have plenty of questions about this study and its implications for the field. Well, without further ado, let's jump into my conversation with Dr. de Vos and find out more. All right, welcome back, listeners. I am privileged to be joined by the lead author of our featured paper, Dr. Bob de Vos. Once again, the title of that featured paper is Deep Learning Quantified Calcium Scores for automatic cardiovascular mortality prediction in lung screening low-dose CT. Bob, thank you very much for joining me on the podcast. Welcome.
Thank you, Praveen, for having me.
Of course. Yeah, it's our pleasure. Why don't we start by learning a little bit about yourself? Where do you currently practice and what are your current academic interests?
Yeah, so to be clear, I'm not a medical doctor. I'm a full-time scientist. I'm a postdoctoral researcher in the Amsterdam University Medical Center in, obviously, Amsterdam in the Netherlands, Europe. And I work in the group of Ivana Ishkum. Also did my PhD there when we were still back in another city quite close to Amsterdam, Utrecht, where I did it at the Image Sciences Institute.
Fantastic. And how did you get into the field of artificial intelligence? So talk to us about the good parts, the bad parts, the highlights, the lowlights.
Yeah, actually, it's quite a funny story, I think. I mean, I don't really have a bachelor or a master background in artificial intelligence. It's more in biomedical engineering. And I became really interested in the imaging part, the modality, the physics behind imaging, but also extended to ECG, so related to biomedical stuff and really acquiring data. And then I figured that this post-processing, I mean, that's an ugly word for most of us researchers now, I realize that, but this post-processing, I really liked that. And I really had an affinity for computers programming. So I kind of went in that direction during my master's. And then I just, right after my master, I had a short stint in the industry, but then I figured I just need to do something more with research. So I Googled some terms, C++, and then medical image analysis, and then constantly these jobs popped up from Ivana Ishkum's group. And then I just thought, okay, let's apply there. And well, the rest is history.
Yeah.
And when I started there, it was before the deep learning hype, and especially the deep learning hype in medical image analysis. But she was already a settled researcher doing a lot of work on machine learning. And she actually had a project, this was really the project, on finding biomarkers in cardiovascular biomarkers in lung screening chest CTs. And well, I figured, okay, this is going to be a medical image analysis. I'm just going to do some relatively straightforward medical image analysis. And I actually said to her, I don't think I will ever do deep learning, but I guess it's quite contagious to go towards deep learning. And the rest is history. I now do a lot of deep learning. I started doing conventional machine learning and really got the hang of it. Yeah, you also had a question about the highlights and the lowlights, right? So
yeah.
So what I found quite interesting and intriguing is that you let a computer learn something. And at first it sounded a bit like magic to me. And I was also a bit afraid of going in that direction, right? I mean, that's such a magical thing that you can make a computer learn something. But in the end, it's all about optimization. And I now see how relatively simple it is. I mean, it's complex in the sense of parameters and how you can optimize and the different solutions you may have. But in essence, it's quite a simple thing and very related to logistic regression or linear regression. I think most of people from the field know about those techniques. So it's very related to that. And then when this deep learning thing took off, and we were all in the group, we already had some experience with machine learning. So it was relatively easy for us to dive into deep learning. And then we saw this kind of paradigm shift. So normally you would want data that was really well curated, get rid of all anatomical anomalies, noise, and that kind of stuff. But now with deep learning, we could just use that as training data and really push these algorithms to the limits. And it was so remarkable that you saw this shift of small developments. I think we can really make now algorithms that you can apply directly in a clinical setting. And so that's, I think, what's remarkable about deep learning. The downside is you work with a lot of data. So
Yeah.
yeah, you have to overcome some of these limitations. So that's really, that can be really difficult. It was really punched into me by Ivana. Leave your test set alone, don't touch it. Don't touch it until the very end. So you can do a lot of data massaging and a lot of stuff if it's only on the training set. So, and then whenever you're going to write the paper, we evaluate it on a test set. And I think that's one of the safest way to do science, to make sure that your method generalizes, that you're not finding some strange hyperparameter, some unique hyperparameter that actually gave you these optimal results. So I think that's one of the best lessons I learned, I think, from her. Leave your data set. I mean, a lot of people say it, but it's really hard not to touch your test set, right? To kind of peek, does it already work? So
that's fascinating. So it's almost as though in deep learning, you can utilize the dirtiest, roughest data and still acquire such like fantastic results. Whereas previously you would have to shape and mold the data before it even gets to the algorithm. Is that an accurate representation?
Yeah, that's really the cool thing about deep learning. And there's also a side note I have to make, because especially in the early days of deep learning, everything seemed to be very simple. You just apply deep learning and it works. But then often the people applying deep learning already worked with these well-curated data sets, right? So that made it seem really easy. It's a bit more difficult than that, but in general, now we just try to throw anything at it and see if it works. So that's really the cool thing. Yeah.
Perfect. This is great background. And why don't we start to talk about your paper in the context of all of this too? So as a reminder to our listeners, the featured study here attempts to evaluate the performance of an automatic deep learning based prognostic tool based on location-specific calcium on lung cancer screening CTs. So obviously there's a lot to unpack here. Let's talk about background for this context. So have there been any studies previously that characterize the quantification of calcium based on location-specific calcium? Has it been used for prognostication before? And if so, how is the study that you guys have performed different than the previous studies that are out there?
There's quite a bit of work already done on location, but then more in a rough sense. For example, calcifications in the aorta versus calcifications in the coronaries, or even some of the main coronaries, right? So, for example, the LAD or the LCX or the RCA. So these different coronary arteries. So that is already known. And I think what we now did is try to distinguish those types of calcification in lung screening CT, but then also try to figure out at which position they are. And it's, don't want to go into too much detail now, but we determine per transversal slice, per axial slice, we determine which calcifications there are. That's quantified. And then based on these slices, we can lump these scores into slabs, and these slabs, they're spatially related among patients. So we can kind of get an idea of if a calcification is more proximal or distal. So it's we also described it in the paper. It's a bit of a proxy measure. There are probably way better ways to do this, but this is just the first step to see if there's more information in calcifications close to the coronary ostia, more dangerous than calcifications further from it. And the same holds for these calcifications in the thoracic aorta. Are the distal calcifications, do they tell us something about cardiovascular mortality or risk of cardiovascular mortality? Or are these calcifications in the ascending or the aorta or the arch more important? So I guess that's more the story we wanted to unravel, to figure out. what is important and what not, and really give people some, or the community, some idea of what a next step in this direction could do.
Perfect. So that gives us a good idea as to what the incremental value of your study is to the field already, where this concept behind location-specific calcium. And remind me, what was the prognostic metric that y'all were using for assessing the performance of this tool?
We used a relatively straightforward model. So our method also consists of two parts. So one is the deep learning part, and really the quantification and the alignment of the images and the quantification of calcium. And the other one is a more straightforward logistic regression approach with Lasso. That's an L1 normalization that makes you select features that, automatically features are selected more important for the prediction than others. And it's a relatively straightforward prediction. So we just determine if someone dies within the next, so if a participant dies within the next 5 years or not. And that's by using such a simple model, we're a bit more certain in our conclusions, what we can say. But there are also other options, of course, to explore. Using Cox regression, for example, to really figure out what the risk is of certain calcifications.
Great. So before we get into the tool itself and the two parts of the tool, let's understand what data you're using in order to train and then test it. From my understanding, the data comes from the well-known National Lung Cancer Screening Trial. The chest CTs in the trial are not actually calcium score CTs. They're traditional non-gated thoracic CTs.
Yeah.
So can you talk to us about how that might impact the accuracy of calcium scoring in general, and then your tool specifically? We don't necessarily have an internal reference standard for the calcium score for these patients. We just have the non-gated chest CT data.
Yeah. So we also didn't validate it against dedicated cardiac CT because we didn't have these CTs. I'm also not really sure if they're there. So we just go by some assumption, right? If you see a white spot in the CT and it's close to the outer wall of the heart, close to where a coronary artery should be, it's likely coronary artery calcification. But it's also really hard in these scans to distinguish them, right? These calcifications. So we do a lot of assumptions there. Luckily, I also listened to this podcast. I think it was number 6 with Michael Blaha. It was a really nice podcast. And the cool thing, right, that you can even do a qualitative assessment of your lung screening CT if there's calcium, if there's a bit of calcium, no calcium, or a lot of calcium, and it still works. So our goal, we do machine learning, and it's relatively hard to tell a machine. This is, no calcium is clear, but this is a bit, and this is high, and this is, so you need to be very clear on what you present as a training target. So we just assume if there are high intensity spots, that's a calcification. It's close to where the LCX should run. But obviously these scans are not ECG triggered, so there's a lot of motion artifacts. But these are also things we attempt to address. So there's a colleague of mine, Sanne van Velze, and she's now working on a method actually extracting even calcifications that are undetectable by the clinically used threshold, which is quite an arbitrary number, right? 130 Hounsfield units. Yeah. She trains with slices with calcium and without calcium. And for every slice, even if it was below the 130 Hounsfield units, you could still see calcification. She used that as a training target. So the machine learned to distinguish calcified from non-calcified plaques. And the cool thing now is that from these calcified lesions or these calcifications, she could also magically turn them into images without calcification and use that for subtraction imaging to really extract only the calcium. And on multiple levels in our group, we're really trying to make it more robust. So even in the case of motion artifacts, we're still trying to find calcifications. And on the other side, we also know that it's really hard to get these numbers from, the true numbers from lung screenings. Now that I'm talking about it, I even think that this Egerton score, we also base it on an Egerton score, but it's also quite an interesting score, right? It has some assumptions. You look at a high intensity value, you look at and you give that a certain multiplier to the area. So it's also not really a score that has a clear physical relation to the true amount of calcium. So in general, I think these calcium scores they work really well, but what they actually indicate is this a low amount of calcium, or is this a medium amount of calcium, or a high amount of calcium? And in that sense, it also looks a bit qualitative, right? This Egerton scores. And in the end, you still stratify it, right, in risk categories, which are also quite arbitrarily chosen. So in that sense, I'm not so sure that it is really important to get the true amount of calcification, although it would be really cool to figure out, how do we get the true volume or mass of calcium from these scans. I know that there are also these phantom models, right? So you have these phantom models and still to get the true amount of calcification, but it's also really difficult to translate these phantom models to real in vivo models, right? To real patients. I think from a lot of directions, we're trying to improve upon calcium scoring, but
Yeah, I think this speaks to what we were chatting about earlier, where you don't have to have this perfectly curated data set going into the algorithm. You can utilize something like non-gated CT scans. We don't need an internal reference standard, but we can still extract meaningful, clinically useful information from those data. Very interesting. So let's dive into that tool that you had developed. From what I understand, there's two parts to this tool. There's the calcium quantification component and then the prognostication component. So first, with regards to identifying and quantifying calcium, the tool it's a deep learning tool. It uses a form of convolutional neural networks, and it works in two parts. There's the cropping of the CT images down to a more manageable size, and then there's the automatic calcium quantification. So can you talk us through that a little bit more, kind of get an understanding as to how that works and why that might be different than the manual calcium scoring technique some of our listeners might be familiar with?
Yeah, so it's a bit of an odd one, the deep learning algorithm I developed for this. So normally what you would do in automatic calcium scoring and in our group, under the supervision of Ivana Ishkom, I think she's really the leading expert on automatic calcium scoring. And normally all these methods follow a certain schematics where they try to copy a manual calcium scoring. So with manual calcium scoring, you visually assess, right, your scan. You see high intensity areas, you click on them, there's a bit of region growing that selects everything that's connected, right? And you scored your calcium. So the convolutional neural networks we use for more the conventional automatic calcium scoring also do the same thing. We try to figure out a high intensity, we look at all high intensity regions. This model then indicates if it's really a coronary artery calcification, for example, or some other calcification somewhere else in the body or in the lungs, or whether it's a type of noise. It needs to learn to distinguish those. And then once you have these calcifications identified, you can calculate the calcium score. So for this work, we used a different approach. We just took a slice as input, and this slice fed into a convolutional neural network. And this convolutional neural network immediately quantifies the amount of calcium in there. So there's no intermediate segmentation step. And that really speeds up the whole process. But it's also maybe a bit more black box. So actually this method consists of 3 parts. We also provide some optional decision feedback that you can go backwards in the neural network and still figure out where did these scores come from with some kind of heat map. So it still provides you with some optional feedback. you also mentioned this cropping, right? Selecting the heart. It's not just to only make it into a more manageable size. It's also to make the chest CT appear more like the field of view of a dedicated calcium scoring CT. So a lot is cropped out of it, so it looks a bit more like a calcium scoring CT. You see the heart, only the heart in it, and it's really then aligned among patients. So there are two techniques we use here. We use so for this alignment, we use deep learning based image registration, and for the scoring, we do a direct regression using convolutional neural networks. And then you have in the end the optional decision feedback. But for this paper, we didn't use that. I mean, we just used the quantities that were outputted from the neural networks.
And I think it's important to note that we're characterizing not just coronary calcium here. We're characterizing thoracic aortic calcium, valvular calcium, but for many of us that are imagers that do calcium scoring routinely, we know it's not all that straightforward to differentiate, say, left circumflex calcium from mitral annular calcium or left main calcium from aortic calcium. So how did you all tackle that approach, or was that one of the potential limitations of the model?
So I kind of live by this idea. If a human has difficulty doing it, a machine learning model probably also has difficulty doing it. But yeah, these models learn from manual reference, right? From expert reference. So if you cannot distinguish it yourself, it's also unlikely that method can do it. So what these methods are really good at is copying a human observer and then be very persistent, right? They're quite deterministic. So if you enter the same image, you always get the same result. So there's not a lot of variability between it. But they do make errors, and they also make the errors that what's in the reference standard. So what we, for example, did is this left main, we just lumped it together with the LAD because it's really hard to distinguish in these types of scans if it's a LM or not. And at some point, you also need to make decisions, right? I mean, these indications of left main LAD, that's also something we as a field make, but these calcifications, they don't really listen to that, right? So they can be partly in the aorta, and at some point you just need to make a decision. Is this an aortic calcification or is this a coronary artery calcification? So that arbitrariness will also be present in these deep learning models.
I like that because, we like to think of this new age of deep learning as something that's just going to solve all the problems that humans have.
Yeah.
But in reality, it too is going to make some of the errors that the humans have made because we are the ones that are training this particular data. Fascinating. I want to jump into the prognostic component of your model as well. This part's interesting because we're talking about slab-based evaluation of calcium. So correct me if I'm wrong here. What we've done is you've taken these calcium scores that have been automatically calculated in the part we just discussed, and you're determining where they are in equally spaced imaging slabs. So is that what you mean by location-specific calcium? And if that's the case, why then is it important to know the prognostic impact of calcium on one slab versus another?
That is one part of the location-specific calcification, right? We also have this differentiation of different coronary arteries. And our question was actually more, can we improve upon, let's say, standard risk factors and just use imaging features? And our hypothesis was actually, do location-based features, do they improve the prediction? And it seems that they do improve the prediction. And I don't know what I can speculate a bit on that, but I honestly don't know what the whole reason is. Why? Could it be due to that there's more motion at some locations and that's why proximal or distal calcifications are more dangerous? But I honestly don't know if it has what kind of effect it has. Is it correlated or is there really a causation? I also don't know. So it could also be an effect, right? That there is something already physically wrong or something wrong in the morphology of the patient, and that calcifications appearing at these certain locations are just an effect. So myself, I'm quite curious why this is the case. And I'm also very well aware that we're working with a very specific data set of people who have been smoking for many, many years, who are already at a high risk of cardiovascular disease, who have a lot of arterial calcification. But still, we were able to, just by these simple, slab-based location features, we could improve our prediction. So I thought that was quite intriguing. But as many other things, I mean, this, instead of answering some questions, we raised many more questions, I think.
So this is interesting. So you're saying that with this slab-based technique, you were able to generate even more incremental value beyond the entire imaged volume alone. Is that correct?
Yes. Yeah.
Fascinating.
Yeah.
Okay. So, I mean, this has been all a setup of the methodology that y'all have used, but let's now get to the quote unquote good stuff, the results. How did this tool perform in terms of predicting 5-year mortality?
We're really predicting 5-year mortality, right? So if they died within 1 year or in 4.5 years, it's a positive, and it's a negative if they survived within the time frame. And we looked actually at the area under the receiver operating characteristic curve. So we did several comparisons. So we looked at the standard risk factors that we could extract from the data set. Then we got an area under the curve of 69%. It's about 70%. If we then added total coronary artery calcification, which is then clinically used, we could increase that up to 72%. And if we then only used our location-specific calcium scores, we got it up to 74%. And we actually think that's quite a nice finding, because we then only use imaging features and no other characteristics that you may need to ask patients, or you need to cross-reference some other databases. So this is really a feature-based thing, which we think makes implementation relatively simple. But then again, if you still add these characteristics, we even get a higher area under the curve of 76%, which was quite nice to find. And I'm now also looking a bit at these. I don't know these by heart. I'm also looking a bit at the p-value between these, and I think especially for these calcium scores we used, we really got some improvement on top of this.
Yes, certainly. And I think it's nice to have that comparison between the traditional risk factors, as you had mentioned, and also total calcium score, and how we do have an incremental increase that is statistically significant of this method of location-specific calcium that's been automatically calculated over, what we would normally think is predictive of risk. So when we would speak to a patient and we extract the traditional risk factors from them, that has driven the majority of prognostication in history. So it's pretty shocking. It's a tough pill to swallow for a lot of clinicians to think that there are exclusive imaging factor-based methods of prognostication that might be more predictive than what we're used to.
Yeah, that's also in what you kind of expect, right? So I'm pretty sure that we will be overtaken by some other interesting finding. And I actually like now what we can do with deep learning. We can start to apply it to large data set, extract a bunch of information, and then really see if we can increase on these traditional risk factors. I still think these traditional risk factors, I mean, I would still advise to use them, right? I mean, this is just a start of something, a direction or a niche maybe, to figure out if there's more in the data. But I do think this is more a general idea I have on deep learning. You sometimes hear that it will replace the radiologist, and I actually think that it will help radiologists. You can just provide radiologists or cardiologists with more information what they can make their decisions on. And the nice thing about these methods is that you can really give them some quantities that will persist, that will, if you do have multiple scans on the same day made of the same patient, that it's not so, that it's consistent, it gives consistent quantity. So I really like that of these methods.
And speaking about the nice thing about deep learning being that we can supplement our normal thinking with robust data-backed information, how does one, as an imager, gain access to a tool like this? I've always found that as one of the potential limitations of these novel works in deep learning specifically, or artificial intelligence altogether. From a community perspective, I'm not sure how I'm going to gain access to these types of tools to be able to implement in our practice. I understand that they may be in the research field at present, but the hope is that we can translate them to the clinical world. How do you envision them coming from the research realm to the clinical world? And where do you think they'll apply best in the clinical world?
This is really a question also for industry, right? So at some point, it's out of the realm of research. It's also difficult, right, to implement that in a clinical setting with all the security regulations in place. And but there are solutions. So also, we as a, let's say, medical machine learning in medical image analysis field are also working on that. So colleagues of ours in Nijmegen University, also in the Netherlands, it's Bram van Ginneken, also quite a well-known name in the field of machine learning. He made a very nice website, grandchallenges.org. And in that website, we can at least upload our algorithms and expose them to the world so that the world can at least try them. So I'm unsure if it's feasible for a clinical workflow, but for clinical research, it really helps. And I think this is, for the rest, I mean, to really integrate it in a clinical workflow, that's really a task, I think, for the industry to implement that.
Even before industry can sink their teeth into things like this, is there any additional validation that you'd like to see for the field as a whole, or even for the specific tool that you've developed for the featured paper? Are there any other data sets or other large registries on which you would want to apply this? Is it even applicable to other large data sets?
I think the quantification part, the calcium quantification part, I would like to see that evaluated on other data sets, and I think it can work now out of the box. I think the prognostic part, so the prediction part, is actually quite specific to the cohort we used. So I think if we were to use them on for example, data from the MESA study, it will completely fail because it's such a specific data set, right? With people, with participants with a lot of calcification. So those are actually I consider them two separate parts.
Interesting. And what about plans for yourself? What is on the horizon in terms of your future work?
Regarding calcium scoring,
regarding
not
calcium
much.
scoring and everything else.
Regarding calcium scoring, not much. So I'm really broadly interested in all cardiovascular modalities, ECG, for example, or I'm currently now on a project working on MRI, cardiac cine MRI, and trying to quantify motion and relate that to certain hereditary diseases. So in that sense, I kind of dropped calcium scoring, but in our group there are still many people working on it and trying to improve. So what I said, Sanne van Velzen is really making some nice algorithms that try to improve reproducibility of calcium scores, even in these non-dedicated scans like lung screening CT or scans for radiotherapy treatment. So just in any scan, and try to increase the accuracy of quantification of calcium in those scans. So a lot will happen. I'm pretty sure I will also be involved in some of this research, but in the near future, I don't have anything lined up regarding calcium scoring.
Wonderful. And how about the field as a whole? What are you most looking forward to in the field of deep learning or artificial intelligence altogether? Some of us radiologists and imagers out there don't have as much insight into the cutting edge as you do, who's truly at that cutting edge. So let us in the know as to what do you think is upcoming.
So what I really think is important, and I briefly touched upon this, is causality. Often in these studies, and also this study, I'm a bit afraid if we're looking at causality or correlation. And I think there's a lot of progress in causality and really trying to figure out if some biomarker has a certain predictive power on some kind of disease or outcome, mortality, you name it. So I think that is really important, and then especially in these more complex models, right? So I'm actually kind of looking forward to more an integration of the clinical research. On the clinical research, you really have these robust statistical models, but they're also quite rigid. You model linear relations, and on the other side, what we use now is these deep learning based models. They're very complex. They can model really flexible relations, but it also there's also a danger in there because you can predict anything. So we try to stay on the safe side with quantifying calcification, for example, or segmenting certain parts in the body. But what would really be cool is when these worlds will integrate, and that you can really have a deep learning based model or a machine learning model that can say, just by having a person and an outcome, and the model learns whatever contributes to a certain outcome, whatever contributes to mortality. So that would be really cool. So not focusing just on calcium, but also on the body composition. Is it about how much fat do you have in the heart, or do you have something funny in your lungs? Or, well, you already hear that I'm not a medical doctor, right? So I use very simple terms.
No, that point is incredible. It's tough sometimes to think that, these algorithms are so complex, but we're pre-specifying the input variables. What you're describing is a situation where we put the data, the raw data, into the algorithm, and it will determine what the most important input variables are. That's fascinating.
I think that's really the holy grail of it. I think everyone doing deep learning has tried to do it, but it's such a hard task. And we're also really in an intersection of fields, and especially in machine learning and medical image analysis, because there's a lot of knowledge we also gain from the fields of computer vision or natural language processing. But a lot of this methodology also doesn't really apply to real world problems such as these clinical problems. So we're really trying to be in the middle of it and try to solve that anyways. But I think this idea would be possible, but then you need quite a bit of computational power. You need really large data sets, and then privacy regulations also kind of hamper the development. I'm not opposed of privacy regulations, but it's, for us as researchers, it's really difficult to acquire a large heterogeneous data set. But that's why it's also really nice that you have data sets like the NLST and the MESA study, that people can just work on really large amounts of data.
Yeah, and from the imager community, we'd like to congratulate and thank you for contributing this work, because certainly someone like me is not capable of comprehending this, let alone even working with it and publishing your information out there so that the rest of us can benefit from it. So truly, thank you very much.
Yeah, thank you for having me. And I'd also like to emphasize, this is really a teamwork, right? So Nicolas Lesman, Pim de Jong, and especially Ivana Ishkum really helped us out with this. So really great teamwork, I think.
Of course. Bob, I really appreciate the time that you've taken to come and share your expertise. Thank you to you and your team for helping contribute information to the journal, and for you for coming onto the podcast. Truly, thank you.
Thank you, Praveen.
Of course. And, there is so much more information just in the paper, let alone in the entire field, that we weren't able to cover in the podcast. So I strongly encourage our listeners out there to go out there and get their hands on the paper. To our listeners, thank you for tuning in. We really appreciate your contributions all the time. If you like what you hear from us on the podcast, please rate, review, and subscribe to us. Once again, this has been the Radiology Cardiothoracic Imaging Podcast. We will see you next time.